Okay, we have another exciting session for the second part of the afternoon, focusing on devices. And for this session, we'll be focusing on therapeutic devices. And the first speaker in this session will be John Giftakis from Medtronic, talking about DBS therapy for epilepsy.
Okay. All right. As we transition from our break, I just want to thank everyone for inviting us from Medtronic here to present our research and technology with you. I just want to disclose that what we're going to be sharing is is under investigation and not approved for clinical or commercial sale. Okay, I just want to provide an overview or a brief update on where we're at with our therapy development for deep brain stimulation for epilepsy. If you can see what's pictured here, we have our therapy essentially consists of an implantable pulse generator that's connected to deep brain stimulation electrodes positioned within the area of the brain called the anterior nucleus of the thalamus. This system was evaluated in a clinical trial called Sante that the results of which were published in 2010 by Dr. Bob Fisher and the Sante study group. And since then, we have continued to follow these patients in this trial long term. To date, we've completed 5 years of data collection, which has been assembled for a manuscript which is in preparation. In addition, the last patient has been followed, so we have 7 years of follow-up on the entire cohort. Discussions continue with the FDA on options for regulatory approval in the US. However, we do have this therapy approved in various geographies outside of the US worldwide, and one of our major focuses this year is on conducting a registry called MORE, where we're collecting both stereotactic functional neuroimaging and clinical outcomes in our European centers. Now, what we're doing at Medtronic is we're developing a new neurostimulation device that has the capability to perform both stimulation and then has various sensing capabilities to it. We call this the Activa PC plus S device. So it's a standard device that we're using for our Parkinson's patients and our epilepsy patients. However, it has this additional added capability that allows us to do things that are necessary for our next generation of therapy. So for example, in addition to recording seizures and recording brain activity, it allows you to do evoked potentials to determine whether you have neural connectivity between a therapy electrode and another remote electrode. It also has a built-in accelerometer that allows you to monitor motion during behavioral seizures and the ability to then download patient-specific algorithms. The research that we conduct at Medtronic is within our physiological research lab. Here's an example of one of the operating rooms in the lab. What we do is we treat these experiments, these preclinical experiments, just like human DBS procedures. So here's an example where we take the animal in the morning, has a pre-op MRI, then goes through and we take those images from the MRI to our Medtronic Stealth station. We then do a surgical planning, and in this particular experiment, we're implanting 2 electrodes, one within the anterior nucleus of the thalamus and the other within the hippocampus. We're using a large animal sheep model. These are sheep that they don't have epilepsy, but we're studying them for standard neurological functioning. You can see up there, we call them the brain radio team. There's 3 sheep in this study. And on the right, just an illustration of how we monitor them. So for example, we'll put one of these sheep there in a sling. We raise them off the floor for about an hour to hour and a half. We can then do sensing and stimulation experiments, and then they get kind of a treat or something after each one they get excited about. So just a briefer on sheep brain anatomy. You can see here that, especially if you look at the right coronal image, that the sheep has a very well-defined anterior nucleus and also a well-defined hippocampus. And this makes for planning the stereotactic placements and for the translational ability of this type of work very rewarding. So a lot of the early work that started this actually came from the early studies from Drs. Fisher and Mirsky, where they showed that when you stimulate the anterior nucleus of the thalamus at very high frequencies, what you're seeing is a reduction in the, or sorry, an increase in the PTZ seizure threshold, so that it's harder to invoke seizures when you have ANT-DBS being implemented. They also, too, were focused on this circuit we call the circuit of Pepez. This is a circuit that's both involved in the generation and the propagation of seizures. So both the anterior nucleus and the mesial temporal lobe are part of this circuit. So the first question we had is, with this new device, we wanted to get an understanding, what would it look like in the brain of a Santé patient if we actually could record while we were stimulating? And so in this preclinical model, what we did was we took the ability or the chance to do this, and we did this both during the intraoperative assessment at time of implant as well as while the animals were awake. So on the top frame, what you can see there is a period of baseline activity that looks kind of ictal or seizure-like. And when you stimulate and you implement cycling, and that's what we do with Santé therapies, that we cycle the stimulation on and off, what you can see is that the brain will automatically change its state. And that state remains as long as the cycling is on. Once you turn cycling off, you see a gradual return to baseline back to that state. And that's very context specific. If you look at the bottom trace, what you see is an example from a recording from the hippocampus, where we're turning stimulation on and off, and during the on periods where you see those black bars, what you see is that in the hippocampus you get a suppressed or quieted effect while the stimulator is on, and you can see that being repeated over and over. Turning the stimulator off, the brain state or the hippocampus is allowed to return back to its normal state before it's re-stimulated. So what happens when you stimulate the hippocampus directly? Well, it really depends on the level of stimulation you're using. With this new device, what we're seeing is that when you deliver low to moderate levels of stimulation, like shown in this illustration here at 0.5 volts, you don't see really any change. Once you go to a slightly higher level of 0.9, you start to see the change in the hippocampus, where you get a quieted effect. A little bit more, and what happens is you now are generating what we call after discharges, or you're creating an excitatory input. And this reflects the fact that when you're within titrating these therapies with some of these structures, it is very, very difficult, and you have to go very slowly. So my last data slide, I just want to show you that what we've been focused on recently is on how does this all impact cortical excitability. So if you're coming from the drug world, this is one of the hallmarks. We look at the effects of drugs on reducing cortical excitability, with the idea that that reduction in excitability is what increases the threshold for having seizures. What we're trying to do here is do that in a focal way. So here's an example where in the top trace, what you're seeing at those arrows are very low frequency stimulations. They're delivered from the anterior nucleus of the thalamus into the hippocampus. We monitor those, and then what we do is we implement cycling. Now, those low frequency stimulations, if you look on the trace number B, they create what's called an evoked response. So that's a response from stimulation generated in the thalamus that now is measured within the whole circuit of Pepez into the hippocampus. When you then look at the next part of that trace, where we have hippocampal DBS cycling, what we're doing is we're reintroducing those evoked potentials, but now in between the cycles. And there's a couple of observations there. One is that the evoked potentials are greatly suppressed as a result of doing that, indicating that that input now is being affected. And second, the overall background of the hippocampus is being suppressed throughout the entire duration of cycling. And the last point I want to make is that if you look at the very right, panel D, what we're doing there is we're taking that same paradigm, but instead of looking at these measures, we're looking at after discharges, or those very brief mini seizures that are created with stimulation. And you can see that if there's one on top where that's just a normal one that we generate during baseline. But if you then proceed that with a stimulation inhibitory cue, what happens is that's either abolished or greatly minimized. So what I think this all means for us is that with the ability to take our open loop devices that we've been programming with intermittent stimulation, and adding this recording capability so that we know how the network's being modulated, it'll allow physicians the ability to tailor the stimulation, to program the devices easier, and to monitor the direct effects of stimulation, which we're not able to really do as effectively as we want to today. So it's a real advancement, I think. I think that's what I want to leave it at this point, you know, and address any questions you have.
Any questions? Okay.
Okay, I'll leave it saying that this device actually is in human studies right now. So, you know, it's further along than just the preclinical work. And I think what we're going to we'll be doing at the next update is providing some evidence and seeing how this has been translated. So,
thank you. Thank you. And next we have Christopher DiGiorgio from NeuroSigma and UCLA talking about trigeminal neurostimulation.
Oh, there you go. So there's the, and then that's the green buttons to advance. Green. Okay, great. Great. Thank you very much to the Epilepsy Therapy Project and the Epilepsy Foundation for inviting me to speak. The dream, or the real goal of trigeminal nerve stimulation is this key message: neuromodulation without implantation. The idea of being able to develop a way to deliver neurostimulation without implantation so that it could be used earlier in the treatment algorithm for people with drug-resistant epilepsy. Let's talk a little bit about the trigeminal nerve. It's a nerve that has bilateral sensory branches in the face. It provides bilateral stimulation. It's very important. We can deliver bilateral stimulation to structures in the brain involved with seizures, mood, and attention. And that's, if I was to remember 3 words from my talk, is seizures, mood, and attention. The trigeminal nerve, it projects to the nucleus tractus solitarius, important for the production of norepinephrine, vagus nerve nuclei, the thalamus, and the cortex. And it uses an external device which could be worn at night or at the patient convenience. We have mechanism of action studies using positron emission tomography via Dr. Cook, who's with us today. We can find areas of deactivation which show that we have deactivation over the primary target area, which is primary sensory cortex, which is the primary receptive field of the trigeminal nerve. But we can actually reduce metabolism over the temporal parietal cortex and mesial temporal cortex, areas that are very important in generation of seizures. But very, very important, in the bottom slide shows activation of areas very much involved in mood and attention. And those are those areas in red in the medial frontal lobe. Now, I believe that these areas of activation explain why we see significant improvements in clinical trials in attention and in mood that I'm going to show you later. We have completed a phase 2 randomized double-blind trial of trigeminal nerve stimulation in 50 patients with drug-resistant epilepsy. They were randomized to either high settings at 120 hertz or a control or active control stimulation settings. The endpoint shown here is 50% responder rate and mood. And what we found was a significant within groups improvement in efficacy with up to a 40% responder rate as soon as 18 weeks, which is a very robust responder rate for an epilepsy clinical trial. And although there was a transient increase in responder rate for the placebo group, that responder rate was not sustained, and there was no significant improvement in responder rate for the placebo group. Importantly, and in the only study ever to show an improvement in mood in devices, we had a significant between groups and within groups improvement in mood, a nearly 50% improvement in mood in those with epilepsy. This is a signature effect of trigeminal nerve stimulation that actually begins before you see the improvement in seizures. You see the improvement in mood within 2 to 6 weeks. In preparation for our pivotal phase 3 trial, which I'm going to show you in a moment, we did a sub-analysis to try to better identify what type of settings and what type of parameters we're going to use in our pivotal trial. To try to minimize variability, we use a parameter of including 4 seizures to 60 seizures per month, and using something quite novel that the FDA has endorsed, the idea of an induction phase. Virtually all device trials suffer from one problem. That is that in the initial 4 to 6 weeks of the device trial, there's a lag of efficacy. that devices do not show evidence of efficacy in the first 4 to 6 weeks. FDA has allowed us to exclude that first 4 weeks from our pivotal trial. So when we use this induction phase, where we can exclude that first 4 weeks of really wasted efficacy, and then we constrain variability by including patients with only 4 to 60 seizures per month. Remember, most device trials and epilepsy trials only allow you to restrict those patients on the low end, but we're going to constrain variability 4 to 60 seizures a month. By doing that, I show you the efficacy here that if we then apply that data to our phase 2 study, something called a bootstrap analysis, we have a minus 34% response in the treatment group versus a plus 6% reduction in seizures in the control group and a responder rate of 53%. This tells us that we have a high likelihood of meeting our primary endpoints in the phase 3 pivotal trial. So the next step is our phase 3 pivotal trial, which we are anticipating rolling out in the next, within the next 6 months. First of all, the indication, adjunctive therapy, complex partial and secondary generalized seizures in up to 350 patients at multiple U.S. centers, including many of the Epilepsy Consortium centers, which have already expressed strong interest. Again, an 8-week baseline, a unique and novel induction phase, which will be excluded from the primary efficacy analysis, and then a 12-week randomized trial. We will also be monitoring quality of life, R ratio, and mood, which again, mood is a very, very important effect of trigeminal nerve stimulation. I want to lead to you some of the other indications that we think, for which we have strong evidence of efficacy in phase 1 trials. First, we'll start with ADD. We've completed a phase 1 trial in attention deficit disorder in children. This is a monotherapy trial without any other drug. We saw a strong and highly significant effect at P of 0.001, showing a significant improvement in the ADHD rating scale, the primary rating scale used for ADD. This is data from Dr. McGuff and Dr. Cook at UCLA. Then Dr. Cook's data in major depressive disorder. These are people who do not have epilepsy, but have had drug-resistant, treatment-resistant major depressive disorder, a virtually 50% improvement in mood, with many of the patients entering complete remission from their depression, with a p-value of 0.0002. A highly significant effect size, and we're currently doing the phase 2 trial, which we hope to finish up in the next several months. And then finally, PTSD, in which we also have highly significant results. So to conclude, there's really 4 messages for trigeminal nerve stimulation. Neuromodulation without implantation. 2, a strong effect on mood and attention. 3, we will be rolling out a novel phase 3 design that has not been used before in the device space that we think could be a model for future device trials. The incorporation of an induction phase that takes into fact that the devices take a while to ramp up their effect. And we'll be rolling out this study in the next several months. We're very excited about this, and we believe that our sub-analysis shows that we have a very high likelihood of successfully meeting our primary outcome. And I want to thank Warren Lambert and the ETP for supporting our phase 2 trial and for inviting us to present to you today. Thank you.
Questions? Yeah.
Dr. DiGiorgio, I have to come here and tell you guys, I have been into this research before, and even though I've moved to San Francisco, I'm an epilepsy patient, and so I haven't stopped this, but his product did help my mood a lot, and from depression that I had before, and since then, and it's gotten so much better. Even though my seizure is not controlled now today, that's because I stopped that. But I'm just here to tell you that this product is very good, and you're a very good doctor.
Thank you, Mindy. I'm very humbled by that. Thank you.
The whole internet is told.
God bless you. Thank you. Yes?
Chris, Is this, have you been able to use this as a predictor of who is going to be a responder of VNS? I mean, this is a clinical,
Well, we're
I mean, a
kind of moving
clinician
beyond
question.
we're moving beyond VNS here.
I know, I understand.
No,
but, I mean,
we're
this
not-
is
we're-
an external versus an internal.
Our primary goal is to show the primary efficacy of this device. Anything beyond that is really a secondary thing. We're really looking at the primary efficacy of this device. But that's an interesting question. But we have to demonstrate the primary efficacy of this device.
Okay.
That's a good question, though.
I just have a question. How durable are the effects on mood or seizures when people discontinue the device?
You know, we don't know. That's a fundamental question that will have to be answered in generally phase 4 studies. Generally speaking, I can only answer the question in the acute phase. We do have long-term data. So I guess the question is, how is the data looking in long-term? So that data is in submission, but I can tell you that from data that has not been published, but it's been presented, that we get a progressive and increased improvement in a % reduction in seizures to a 35% median reduction in seizures at 1 year, and that the responder rate remains stable at 37%. So we see a stable responder rate. So we get this rapid induction of response, a stable responder rate at 1 year, and then a continued improvement in the median reduction of seizures up to 1 year. But that data hasn't been published in publication form, but it's been presented at the meeting. So I can tell you it's very positive. Yes.
Have you, just step up to the microphone. I'll repeat the question, sure.
It's about the practical use. So, you know, how to place the electrodes, duration of stimulation, and any side effects you see during and after stimulation.
Okay, so
repeat the question.
Okay, so the question is, what are the practical aspects of this device? How do you place the electrodes? What's the duration of use, and what does it feel like? Is that okay? So the electrode is designed to be self-centering. It has a chevron shape. So the patient can apply the electrode always knowing that it's midline, because the electrode is designed to stimulate the supratrochlear and supraorbital branches based on the known variability of the anatomy of the supraorbital and supratrochlear nerves. So the patient has a self-centering electrode that's designed so that they don't have to measure out the nerve. Second is that we recommend a minimum of 8 hours and generally 12 hours, usually at night, of therapy designed by the doctor. So it can be generally worn at night with some flexibility there. What the patient experiences is a subtle tingling sensation. Generally, they feel a mild tingling sensation, which is a very pleasant feeling that they generally get used to. Much like at VNS, you get used to that tingling sensation. And it's adjustable. If they feel any discomfort, they can immediately self-adjust the current. So those are good questions. All right, thank you very much.
Thank you. Our next speaker, also from UCLA, is Dr. John Stern, who will be talking about ultrasound for seizure modulation.
Thank you to the organizers for this invitation, opportunity to share these initial foray into a new technique for seizure treatment. So focus ultrasound has really two possible directions for epilepsy. There's a technique that includes ablation or tissue destruction that is, I think, more widely recognized than the modulation technique, and I'll be talking about the modulation technique. Essentially, the difference is the intensity, and the intensity of low-intensity focus ultrasound is one that can have biomechanical effects on the membrane to change the capacitance properties of the membrane and thereby affect the excitability of the neuron. We know that the focus ultrasound output, both mechanical and thermal energy, is far less than high intensity, and here in this table in front of you, it's comparable to or compared to a lithotripsy, which for some of you who aren't familiar is a technique of ultrasound to destroy hard particles. It could be used for kidney stones, to dissolve the stones within the kidney, or physiotherapy, which is a heating technique. So you can see that high-intensity focus ultrasound has higher mechanical and thermal properties than low-intensity, and lithotripsy and physiotherapy differ and are along a continuum between them. I'm not going to take you through the math of the membrane effects. The point is to affect the output from the neuronal system. And this can be done either to increase or decrease excitability, depending on the parameters, which are essentially through the pulse width and the frequency. In animal models, in this case a rabbit, one can block visual evoked potentials through decrease of excitability or produce movements through increased excitability. And you can monitor this with functional MRI. What's depicted here is the bold response. It's an increase in perfusion or metabolic activity within a region based on targeting of the focused ultrasound beam to motor cortex. Functional MRI can modulate or can detect the modulation change. However, thermal MRI can detect any heat change, and we know from those experiments that the low-intensity focused ultrasound does not affect the heat in a significant degree within the brain. This has been pursued in an animal model for epilepsy, and this is a pentylene tetrazole model for rats, showing the peak EEG signal indicating seizure activity. Baseline, of course, very little. After the induction of the epileptogenesis, or the seizures more accurately, there's an increase in activity that's similar in both the red group, which is the group that received the focused ultrasound, and then the blue group, which is a control group. After focused ultrasound, there is a decrease in the activity of the peak, and that continues to go down. The model here includes 3 minutes of focused ultrasound stimulation to decrease activity, followed by 10 minutes of recording. The significance is seen both between the focused ultrasound group and those who did not receive it, but also within the focused ultrasound group to the point prior to initial stimulation. Histopathologic analysis of the tissue from these animals shows no tissue destruction, so this clearly distinguishes it from an ablative technique with focused ultrasound, and shows the key aspect, which is truly neuromodulation. Our plan, and going forward in humans, is the first in human use of this technique, and we have a device which is MR compatible, in which we can deliver the focused ultrasound, the low intensity focused ultrasound sound to the temporal region. The yellow you see in the MRI axial section is the beam of the stimulation. The beam can be moved in a anterior to posterior direction to cover the anterior temporal lobe and have a focused region of effect that will presumably modulate. The area of involvement is, of course, much smaller than the window that is typically resected from epilepsy surgery. Our protocol, which is just now beginning, takes individuals who have been offered anterior temporal resection, people with temporal lobe epilepsy that have not responded to treatment with medications, and offer them the opportunity to participate, which is purely for safety reasons. The patient, after consenting and going through a screening process, has an intervention that is days to a week or so prior to the scheduled resection. In the intervention, neuropsychological testing is done prior to stimulation. Stimulation is done in the MRI scanner with monitoring of bold, signal change. EEG is performed prior and after the stimulation, and neuropsych testing is performed again after the stimulation, with the idea of identifying any change in function due to the stimulation in these individuals. The patient then proceeds to surgery as scheduled for resection of the tissue, and the tissue provides an opportunity to determine in humans whether there's any evidence of histopathologic change or destruction of the tissue from this. The group of collaborators for this is diverse in background, and I think this is an example of a technology that comes to epilepsy because of the opportunities within epilepsy to determine efficacy or response and modulation, with the idea that if this is safe and efficacious in epilepsy, it certainly has opportunity to expand beyond epilepsy to other areas of modulation. It differs from a more established form of modulation, transcranial magnetic stimulation, in that it provides an opportunity to stimulate tissue that's deep within the brain with a focused region, which is, of course, I think as was discussed earlier, a problem with TMS, in that one can't target as easily and cannot go as deep. So, thank you very much.
Time for a few questions. I have a question. In the animal models, or based on theory, how many sessions, or what's the dosage, the duration of focused ultrasound treatment that would be required to treat somebody's refractory epilepsy? Is it something that they'd have to do for life?
that's an important question, which is we're maybe 2 or 3 steps before that. So in the animal studies, it's been for minutes of stimulation. Acute seizures can be aborted with the focused ultrasound. The question then is, in humans, well, how you go forward? It'll probably be similar to what was done with the TMS experiments, where individuals come in for routine therapy for neuromodulation that way. And just to be clear, there's no need for craniotomy or any change or surgical intervention. This is all done through the skull.
Just wondering, what parts of the brain do you think you're going to be able to target?
Well, the prime target right now is the anterior temporal lobe, and that's partly due to the thin bone just outside that. So it provides a window for stimulation that's quite easy. And it's to be also more uniform patient groups. That's where we would start after this initial safety experiment finishes.
Right. I know that's where you're starting.
So you're asking beyond that. It ultimately will be determined on how well identified the epileptogenic region is. That if we can provide focal modulation of a region to decrease its excitability, then the efficacy of this will depend upon how well circumscribed that region is. So it's not going to depend as much on the ultrasound technology as much as the diagnostic evaluation.
So you think, I mean, I'm asking, can you like angle with the bone and everything and target all parts of the brain equally?
You can target much of the cerebrum equally. And in animals, we can get to the thalamus, so that's not as far.
Just a simple technical question. When you're using the other kind of ultrasound, where you are actually trying to ablate something, heating the bone is a big issue and stands in the way of a lot of things we'd like to do. I presume with this particular technique, heating the bone is a non-issue. Is that correct? Right. The energy released in this low intensity is actually just below the use, the energy of diagnostic ultrasound. So although it's focused, it doesn't produce the same heating as one gets with other forms of ultrasound. Thank you very much.
Great, thank you.
Okay. Next, we'll have Ashok Goda from Visualase talking about laser ablation.
Thank you. I'm Ashok Gowda. I'm the co-founder and chief operating officer at Visualase. And today I'm going to talk to you about our minimally invasive technology for neurosurgery. So everybody here probably knows that there are at least 1 million people in the U.S. that are refractory to all medical therapies for epilepsy. What people might not know is that of that population, there is anywhere from 1/4 to 1/2 of them that are probably good surgical candidates. They're probably a part of their brain that you could go in and resect, and they become seizure-free. So why is it that despite this knowledge, and despite the fact that surgeries are generally safe and effective, only about 3,000 cases get done in the U.S. every year? Well, there are a number of reasons that happens. One of them for sure is depicted on this picture on the left, and it's the fact that you have to go through a craniotomy. This is a procedure in which a large skin incision is made, a section of the bone about the size of the palm of your hand is removed, and you traverse tissue, which is often critical tissues, in order to get to the area you need to resect. We have a joke in our company that the only person for whom a craniotomy is not a big deal is a neurosurgeon, right? For everybody else, this is a pretty big deal. So what we've done at Visualase is we've developed a technology to try to replicate what otherwise we would resect through a thermal ablation technique using a laser device, which is MR-guided laser therapy. And this is depicted here on the right. Obviously, these are cartoons, but it gives you the general idea. The procedure is minimally invasive. It allows the patient to place this probe, allows the doctor to place this probe into the head through an access hole in the bone, no bigger than a coffee stirrer. And so the typical hospital stay is 1 night. These typically no ICU stays associated with this procedure, minimal pain, and there's pretty rapid recovery. Some of the patients that have this therapy come in on a Friday. They're literally back at work or back at school on a Monday. So I think that highlights the nature of how minimally invasive it is. The technology consists of two components. There's a workstation component that has a computer workstation and a laser unit. This is designed to interface with your MRI unit, and it provides real-time thermal feedback during the procedure. The other component is a disposable laser applicator. This is 1.6 millimeters in diameter. It's smaller than most biopsy needles that are out there on the market. This is the business end of the unit. This is what does the actual ablation. This is how we deliver the laser energy into the target. It consists of two components. One is an inner fiber optic that you see glowing red. The other is an outer cooling catheter. Cooling tissue may sound counterintuitive when we're trying to actually heat it and destroy it, but what we're really trying to do is prevent char and carbonization. Once you char tissue or once you carbonize it, that light laser energy no longer is able to penetrate, no longer able to create that ablation zone. So one thing I want to mention, when we originally developed this technology, we were targeting brain tumors primarily, and that was a very tough place to commercialize. So what we learned is that there are a lot of options in brain tumors, and we were put at the very end of the line. We started looking at this epilepsy space, and it was really the grant that we received from the Epilepsy Therapy Project that helped catapult us both in all disciplines of our company, because it allowed us to, one, show that this has an application in a space where things like stereotactic radiosurgery and things like that aren't frontline. There's a huge unmet need. Many of the patients and parents of these patients don't want to undergo the large open resection. So again, it was a perfect place for us to start demonstrating the utility. Our first procedures were performed in some pretty difficult areas. This is, oops, not sure what happened to that video, but it stopped. Let me try this again. What you're seeing here on the left is a thermography image of a tumor. It's actually it's a lesion that sits just below the hypothalamus. It's called a hypothalamic hamartoma. I apologize, I see it's misspelled here right now. I took this slide from one of our marketing decks, but so I just noticed that. But anyway, not me. I'm going to blame it all on my marketing guy. I know how to spell it, I promise. The middle image there is a damage estimate, and so that's based on the temperature time history that you're seeing as we're delivering the laser energy. So every 5 seconds, the physician is actually viewing this in real time. He's able to see exactly what tissue is dead, what tissue is alive. There's some other features of the software which aren't shown here, but you can place temperature limits on any critical structure. You can, such that if those limits are met, it automatically feeds back and shuts down the laser. So the physician has very tight precision and control over the therapy. On the very right is a post-contrast image showing exactly what we did treat, and you can see the very close correlation between that damage model and what was actually treated. Now, this is, these hamartomas are a very interesting case because we've treated about 70 of these now, and it was funny. I was just at a lecture by Dan Curry, who's treated the most of these at Texas Children's Hospital in Houston. He was almost embarrassed to present his results because he's got a 93% seizure-free rate in these patients, and it almost sounds unbelievable. And he almost felt like it was hard for him to even present results that good. So again, this is an operation which otherwise would be quite invasive. You're dealing with an area deep in the brain, some of the most highest priced real estate in the entire body. And we're able to accomplish this same procedure in a matter of minutes with the actual ablation and send these patients home within 24 hours. The second case study is ablation of amygdala and hippocampus. These are the mesial temporal lobe structures, which are most often targeted for adult mesial temporal lobe epilepsies. Again, what's really interesting about this, if you look at the structures which you would have to resect through in order to get to that mesial temporal structure, and some of the most exciting data that's emerging right now is the neurocognitive and the neuropsychological benefits of not doing that resection through those mesial temporal structures in order to get to these two, the resection through the lateral temporal structures in order to get to the mesial structures. Here we can accomplish the same thing with a series of about 5 serial ablations along the length of that hippocampus and amygdala. And again, these patients go home within 24 hours. Here's our demographic slide. We've treated over 700 cases have been done in neurosurgery. That includes both tumors and epileptic foci cases. I just got the results hot off the presses today. We are now at 404 patients with epileptic foci. And again, it's a mix, about half and half adult and pediatric. You can see that the majority of those in the adult cases have been mesial temporal lobe cases. We're at 70 now, hypothalamic hamartomas, and we've treated other lesions as well, cortical dysplasias, tuberous sclerosis, even some non-lesional cases that are based on correlation of high-density EEG, magnetoencephalography, and PET scanning. So I'd just like to say, personally, this has been an incredible space to work in. The technology has had such an impact on patients and actually just the whole company itself. The stories we get back from patients and after these treatments is it's really moving to everybody involved in the company and the technology. And I hope I have the opportunity to continue to do this for a long time. It's very exciting. Thank you.
We have the opportunity for some questions.
Yeah, how do you demonstrate scientifically that this product has efficacy in the treatment of epilepsy? Now, I don't know what the regulatory situation is. Presumably you can market this as a device for surgery, whether you can prove efficacy or not, but for it to be adopted, obviously there has to be scientific information. So how do you get that information?
Yeah, so this technology was originally cleared as a surgical tool, right? So it has a very broad indication. We're still cleared as a surgical tool. We're cleared for soft tissue ablation and neurosurgery. We don't have a specific disease state indication. We don't market it for that. So what you have to do when you have a tool is you have to go out and collect the data in order to be able to prove that it's effective. And the grant we got from the Epilepsy Therapy Project was very helpful in that regard. It allowed us to do our initial feasibility studies, if you will. These are post-market studies, but they were in patients with epileptic foci that we were ablating. That data is just emerging. We have since used that data, as well as, really the fact that we received that award was sort of validating for the technology, and it helped when we went to new sites to help them understand the technology. And we've used that to broaden the scope of where this is being used. The data is early, I'll agree, but it is emerging. We have patients now that are out 3 years that are seizure-free. We have a cohort of patients in the mesial temporal lobe cases that are out past a year with efficacy rates of greater than 50%. And again, these are, what I'm saying are these are seizure-free rates. These aren't seizure reduction rates. So if you talk about responder rates, I mean, these numbers go up to 80, 90%. So, a lot of data is going to be necessary. More studies are going to be needed before this is adopted everywhere. But I think the data right now is very encouraging.
Actually, you might have just answered part of my question. One of our volunteers learned about this procedure recently and is quite interested in learning more and taking it to his doctor. Where can people with epilepsy get this procedure done right now?
There are about a little over 40 sites in the U.S. right now that are offering this. We expect to be in 75 by the end of this year, so that number is growing rapidly. We have there's a section on our website you can go to, and you can find a physician, if you will, or put an inquiry in through our website, and it'll tell you depending on what state you're in, we can refer you to the closest center.
All right, perfect. Thank you.
I feel like an overbearing parent here, but what do you think happened to the other 7% that didn't make it to be seizure-free? Why only 93% seizure freedom? Like, did you learn something from those 7%?
Yeah, well, so I was referring to those specific patients with the hamartomas, the hypothalamic hamartomas, and so I'll put in a disclaimer there. 4 of those patients, I think it was a group of close to 20 patients. I remember the exact number, but of those, 4 of them were retreated. So the other thing about this technology is patients will sign up for a second treatment because after the first and after they see the impact of how quick the recovery is, they'll easily sign up for a second. So they've actually gone in and treated 4 patients twice. And so of the ones that didn't become seizure-free, there means there's still tissue remaining there that they weren't able to ablate or they didn't achieve removal of. Because generally with those lesions, especially in the hamartomas, if you get a complete disconnection or you treat the entire lesion, you get pretty rapid recovery.
One last question.
Have you tried this technique in multifocal patients?
Yes. So some of the things that were listed there, tuberous sclerosis, for instance, we've ablated multiple tubers. We've done it both at the same time, and we've done it serially. We've done it with some of the periventricular nodular heterotopias, and we've done it with tumors. Many cases of tumors where we've done multifocal. It's not in the same space.
And do you think that the seizure freedom that you observe is a function of accurate source localization? So if there was an error in source localization, would you have expected the same level of seizure freedom?
No, I mean, so absolutely, you have to know where the seizures are coming from. I mean, this device is, you know, it's same thing for resective surgery, right? If you haven't localized the seizure onsets, then and you resect the wrong areas or resect an area that's, you know, not responsible for seizures, then you're going to get the same result here. So most of the stuff we focused on has been lesional-based epilepsies, which have correlated highly with, you know, the EEG, external EEG. There's a lot of people these days that are doing stereo encephalography, and that's really helping with this technology because that's a minimally invasive technique for localizing seizure onsets, and followed by minimally invasive therapy to potentially treat them.
Thank you.
Thank you. Our next speaker is John Snell from Swedish Neuroscience Institute, who will be talking about MR-guided focused ultrasound for the treatment of temporal lobe epilepsy.
Good afternoon. I am John Snell, but I'm not from Swedish. I'm actually from the Focused Ultrasound Foundation, and in partnership with Gwen Ryder and Stephen Monteith at the Swedish Neuroscience Institute, we have kicked off a project to look at the feasibility of MR-guided focused ultrasound for mesial temporal lobe epilepsy with the kind support from the Epilepsy Therapy Project. I am not a doctor. Well, I am a doctor, but I'm not that kind of doctor. I'm an engineer. The neurosurgeons are in their ORs today, which is probably as it should be. So I trust in your kind questions. So maybe a word about the device for those who are unfamiliar. This is a picture here on the right is the Exablate Neuro. This is a hemispherical phased array of 1,000 piezoelectric elements. It can put out a peak power of 4,000 watts, although we never see that practically. This is actually the unit that's at the Swedish Neuroscience Institute. We have a duplicate at the University of Virginia, which is adjacent to where the foundation is located. So we're blessed with access to these devices. So the challenge is to see whether we can reach far enough in the brain. This device is under clinical investigation currently for movement disorders. Essential tremor is in a pivotal now, which we anticipate will be through recruitment by the end of the summer. And pilots are ongoing now for Parkinson's and OCD, and a few other indications are about to start. But most of these indications are very central targets in the thalamus or very nearby, and the challenge is to see whether we can reach far enough into the temporal lobe to make this practical. Obviously, if this could work, it offers a non-invasive alternative to some of the other things that we have to offer medically refractory patients. No radiation. We can repeat this a number of times, as the previous speaker said, if necessary. No incisions whatsoever. At the current time, you do have to have your head shaved, but we hope to overcome that eventually as well. Previous cadaver work, we were looking at trigeminal neuralgia and a few other indications, and using whole fresh cadavers to kind of do a survey. And at that time, we saw that we could make a focus in the hippocampus. We could get pretty near to clinically relevant heating, it looked like. So on the left is kind of the planning image with the target focus in the hippocampus, and on the right, toward the middle is the hot spot. The noisy stuff at the bottom is artifact from the bone. But again, as in the Visualase device, we're using MR, not only for targeting, but also for monitoring in real time the heating that's produced at the focus. So in order to do a bit more of a scientific and repeatable set of experiments to see what the extent of heating that we could achieve, we developed this phantom, which is the combination of an ex vivo skull. We began with whole fresh cadavers and got CT and MR imaging of both, salvaged the skull, and then created these molded gel phantoms that basically fill the entire intracranial space. So on the bottom here are 3 planes through the skull showing 2 pieces. The gel phantom is molded in 2 pieces and inserted carefully so we don't have air bubbles or anything. And basically then being able to register the CT to correct for the skull aberration of the ultrasound, and having the MR registered, we have actual anatomy that we can target. So what I'm going to talk about today are 4 experiments over 3 skulls, and in particular this skull, which we did on 2 successive days with 2 different durations. So typically for thalamotomy, you'd see a sonication of about 1,000 watts for 10 or 12 seconds, and so that's kind of where we started. Doing a reference sonication in the area of the VIM and the thalamus, since we have some clinical experience to kind of say that we're confident we can reach ablative temperatures there. We always start with doing this reference heating, which is shown below. So that kind of gives us a rough estimate. So these are gels in here. There aren't real brains. There's no perfusion. They don't heat the way patients do. So we have to have something to roughly calibrate. Anyway, so at the standard exposure time, we get kind of a limp heating. We're far enough away from the center of the brain now that we're kind of reaching the edges of the envelope of this device, at least for thermal ablation. And so on the next day, we upped the exposure time to 30 seconds, which had the benefit of getting us, the heating range goes up to 14 to 20 degrees, so we're in the ablative range. Has the nice effect also, the increased exposure time causes more diffusion of the heat, so we get a larger hot spot. So the normal lesion that one would make in the thalamus is on the order of 2 or 3 millimeters, and if that was the bite size we were going to take in the hippocampus, it would probably not be time efficient for practical treatment. But if we dilate that volume quite a lot by using a longer sonication, then it starts to be feasible. So we think we can heat enough in the hippocampus and the amygdala, at least according to this model. However, the issue, particularly with longer sonications and being this low in the skull, is the bone heating on the floor beneath the hippocampus. So in this experiment, we also instrumented the skull floor with a number of thermocouples, and I've artificially colored the tips of the wires red because they're kind of hard to see. So there are a number of important anatomical things there that we're concerned about the temperature, and we monitored these thermocouples in real time during the sonication to see how much actual bone heating that we would see. And the worst offender, and again I'm showing the 10-second and 30-second sonications, the worst, these are the maximum temperatures that we saw. So for the longer sonications, which are the more effective ones, the worst offenders are the petrous bone and the fossa and the internal acoustic canal. Now, from the previous study that we did with trigeminal neuralgia, we found that by turning off the superiormost part of the array that basically shines directly down on the bone, that we could decrease these temperature rises 10 to 12 degrees. So we think by using this shielding technique, and you can actually draw on the planning station areas that you don't want the ultrasound to go through. So by drawing these areas that are sensitive to skull floor heating, we can have the system automatically turn off a part of the array so that they don't see this direct impingement of the ultrasound without really affecting the ability to heat the target at the focus of the array. And at the bottom right, which most of you can't see probably, you can see again, this is the worst of all the sonications. The petrous bone heated almost 24 degrees here. And really what this shows is that even though that particular structure, which was right under the sonication, got really hot, all the other thermocouples really heated very modestly, 5 degrees or so. So again, I think the story is that even though this is a concern, rightly so, we can manage it. Also in this model, again, there's no perfusion, there's no CSF or anything else that hopefully would make this less of a problem than it appears in this model. So in conclusion, this is a small amount of data, but it does look like, technically speaking, treatment of mesial temporal lobe epilepsy with focused ultrasound is feasible. Skull-based heating is the big concern, but we think it can be managed carefully. And we're kind of in discussions now with my colleagues at Swedish about whether we need to start talking about putting a protocol together for a small pilot study, which is the second phase of this project, should we all agree that that's a good thing to do. Moving further in the medium to longer term, right now the clinical transducer is working at 650 kilohertz. We're looking at another Insightec transducer, which is lower frequency, 220 kilohertz, which has the benefit of not being affected by bone as much, has a much bigger working volume in the head, and has a larger focal spot size, so it should be more time efficient. There's a lot of discussion about treatment strategies. Are we really looking to emulate something like the ROSE trial, where we're doing a wholesale ablation of the entire mesial temporal part of the hippocampus and amygdala, or is there a disconnection strategy that might be more efficient? Technically, on the engineering side, we think there's probably room to improve the way that we're refocusing through the skull, so that even with the current device, we can reach farther without losing efficiency. And then finally, clinical experience with movement disorders has shown that skull properties do matter, even for the essential tremor, pivotal, patient skull thickness, shape, geometry matters, and may be subject to being factored into patient selections. I want to really thank the support of the Epilepsy Therapy Project and also the Focus Ultrasound Foundation to donate my time. Thank you so much.
Time for one question. No questions, we'll move on. Thank you very much. All right, and the last speaker of the day, of this session, is Alex Rotenberg from Boston Children's Hospital, who'll be talking about TMS therapy for treatment of epilepsy.
Thank you. Thanks for letting me talk about non-invasive brain stimulation, specifically this kind of non-invasive brain stimulation in epilepsy. I have no meaningful disclosures. So just by way of introduction to transcranial magnetic stimulation, this is a means to non-invasively stimulate the brain with small electrical currents. There is, as many of you know, maybe a robust body of literature looking at how strong magnetic fields affect living organisms, but this is in fact electrical stimulation. The mechanics of this are relatively straightforward. There is a handheld electromagnet that's positioned next to the scalp. It generates a brief, approximately 2 Tesla magnetic field that induces electrical current everywhere around it, including in the brain if it's positioned next to the scalp. And this image shows that the most conspicuous part of the brain to stimulate is the motor cortex, because it gives an obvious output, a movement of a limb. And the magnitude of that movement, which can become a measure of how excitable that part of the brain is, can be quantified very easily with surface EMG electrodes. And so that's my way of saying that TMS has a very interesting place among brain stimulation devices in epilepsy, in that it has potentially both robust diagnostic and therapeutic capacities. It's a means to measure how excitable the brain is and perhaps what is the function of a regional volume of cortex, as much as it is a way to modulate cortical excitability. And roughly, cortical stimulation can fall into 3 flavors. Repetitive stimulation that can be used to modulate how excitable the brain is. Single pulse stimulation to see if one gets an evoked response to measure how excitable it is or what function that part of the cortex performs. Or paired pulse stimulation, and bear with me on this, I'll show a few slides on it, as a means to test regional cortical inhibition and excitation capacity. And so the low-hanging fruit for application of TMS in epilepsy is what's shown in the right panel, which is a patient from the Brigham and Women's Hospital, an adult with a ring-enhancing lesion who is going for surgery. And the question for this patient was, is there motor function in the region of that lesion? And this is an FDA-approved use of TMS. And with stimulation of that part of the cortex, the panel on the bottom right shows a very measurable motor-evoked response from the contralateral hand. suggesting that this is where the patient's motor function is. And so we've actually put this into day-to-day use in epilepsy and now have it as part of the surgical workup for epilepsy patients who may have surgery that may approach the eloquent cortex, specifically the motor areas. Other centers are also now looking at using this routinely to map expressive language and hopefully soon also receptive language. The FDA status of TMS devices is interesting. There are two devices, the Neuronetics device and the BrainsWay device, approved for treatment of major depression. There's one device, which is where the data in the previous slide came from, the Nextim device, which is FDA approved for mapping motor and language areas, interestingly across ages, where the other ones are for adults. And just this year, there was a handheld single pulse device approved for abortion of migraine with Aura. The glass half full version of these FDA approvals is that a couple of them came through the 510K mechanism, which means that now the gates are open for manufacturers to start producing these devices, and our hope is like any other electronic gizmo, they'll be cheaper and better from year to year, and now there'll be some competition in the TMS market. And so, thanks to the Epilepsy Therapy Project, we've actually applied TMS in temporal lobe epilepsy. Previously, over the past few years, there have been a few trials, and as Dr. Fisher mentioned, some of them successful and some of them not, where some patients do indeed respond with seizure suppression with repetitive, low-frequency stimulation of the cortex. It turns out the ones who are most responsive and where the operator is most successful is where the cortex is targeted accurately, where the seizure focus is conspicuous and identified and close to the brain surface. Yet that leaves temporal lobe epilepsy off the menu. The seizure focus is often too deep for the conventional kind of TMS coil, the kind that's in the cartoon here, which stimulates only a few millimeters beneath the skull. But the more recently approved device, the one on the right, the BrainsWay device, which is the company that actually partnered with us as part of the Epilepsy Therapy Project grant, generates a coil that has an array of electromagnets in the top left panel that can stimulate a few centimeters beneath the surface. And they have been kind enough to customize for us a device that's in the bottom right panel, which stimulates deeply either the left or the right temporal lobe. Temporal lobe is a little bit of an overstatement. It's the posterior quadrant. It's a coarse stimulation, but deep enough potentially to reach the mesial temporal structures. And so we've been recruiting patients, and I can tell you what we have so far. We've been slow to recruit patients and a little bit inefficient in getting them to come back with their seizure diaries. But the ones that we have, the data look encouraging. And so these are the data from the complete data sets from a protocol that involves a month of daily seizure diary, followed by an EEG and a neuropsychological battery, 2 weeks of daily 30 minutes, 1 hertz stimulation of the affected or most affected temporal lobe in the case of a bitemporal epilepsy, followed by a follow-up period with the same 1 month of seizure diary, neuropsych battery, and EEG. And indeed, there's a separation even in the small sample between the verum and sham group. There is one patient that did not behave like the other verum-stimulated patients. And as Dr. Fisher mentioned today, this was a patient whose seizure focus was not adequately targeted. In hindsight on EEG, this was a patient with a mix of multifocal and generalized seizures. The other patients with primary generalized epilepsy did well. This underscores a little bit of work that we had done some years prior with conventional TMS and superficial stimulation, where we sorted patients as to whether or not the stimulator was placed over their seizure focus or over an approximation of their focus or not over their seizure focus. And indeed, there was a group, which is the circle all the way to the left, that preferentially had seizure suppression, and those were the patients whose seizure focus was easy to see and easy to target. And as we're analyzing these data, we can look at some of these in a little bit of close-up. These are data from one of the subjects that had a favorable response to RTMS. The block of 10 days is marked in the red line of daily 30-minute stimulation. The patient's seizure counts day to day are on the y-axis. And we can see that this patient had an appreciable seizure suppression, was actually seizure-free for a few days during treatment, and relapsed relatively quickly on a scale of a couple of weeks. So what we've been doing with this patient and others like her is bringing them back for more TMS. We had the same, well, I had the same discussion with them as I do with every other patient. If a treatment is not working, it's for one of two reasons. It's ineffective or there's not enough of it. And so we've been cautiously in an open arm of this trial now, stretching the stimulation to 15 business business days, and we'll see if we can adjust other parameters to see if we can have a either longer lasting or a more favorable response. Now, the threshold question, though, for us was, could we do harm by stimulating the temporal lobe with a kind of protocol that depresses cortical activation? Plausibly, we could have contributed to hippocampal dysfunction and a deficit in declarative memory. Luckily, though, on the Wechsler memory scale, we do not see any of it. Not only that, you'll notice that these bars are in magnitude different than the bars from all the other favorite responses, and so far we don't see a real coupling between the extent to which seizures are suppressed and the extent to which memory is affected. But stay tuned, we'll get more data about this. But what we can say now is so far the side effect profile has been very mild in this. And then for the last part of this, I just want to underscore that this is a really good time to be in the non-invasive brain stimulation business, because in the clinical arena, these devices, transcranial magnetic stimulation, transcranial direct current stimulation, random noise stimulation, etc., have run far ahead of the basic science. And we have an opportunity to do something really cool, which is apply these things in animal models and really govern the deployment of these devices that are already out there in the clinical field. And so this one kind of protocol called paired pulse stimulation is particularly interesting. So imagine stimulating the motor cortex in a subject twice, so that the two stimuli are separated by a couple of hundred milliseconds perhaps. And the amplitude of the motor response after the second stimulus in the right-hand panel is never as big as the first. It's predictably smaller. And that's presumably because the first conditioning stimulus activated a GABAergic inhibition, and depending on the interval, either regional or maybe even global. And then the second stimulus produced a smaller dampened evoked response. We've adapted this to rats, and this is a slide that I showed when I was lucky enough to give this update last year, and found something very interesting in a traumatic epilepsy model, a post-traumatic epilepsy model, which is a progressive loss of this GABAergic, you'll have to take my word for it from other studies, intracortical inhibition as a function of time after traumatic brain injury. The value added to the clinical arena from a study like this is now we have a marker not for the epilepsy but for the epileptogenesis. As early as a week after injury, before the clinical seizures develop, we can sort subjects by whether or not they have lost an appreciable amount of cortical inhibition as measured by this kind of TMS. And where we left off last year was that we're going to look at the biology of this, which turns out to be pretty interesting. What we see in about the same time scale, if we stain the perilesional cortex in this fluid percussion, traumatic brain injury and post-traumatic epilepsy model in rats, is a progressive loss of a particularly delicate but important cell population, the parvalbumin-positive inhibitory interneurons. These are cells that are firing nearly constantly. They have a tremendous metabolic demand, and they drop out if you look at them wrong. They're very delicate cellular elements in the cortex, but they amount to 40% of the inhibitory interneurons in the neocortex. And so even a modest loss of these cells can translate into appreciable loss of cortical inhibition. And again, the value added of this kind of non-invasive brain stimulation measure is that we can survey how well is cortical inhibition working and how healthy is a population of cells like this one. And so to follow this up, in a separate line of work, funded in part by CURE and the Department of Defense, we've been looking at beta-lactam antibiotics, penicillin and its cousins like ceftriaxone, at improving glutamate transport and mitigating some of the excitotoxic injury after traumatic brain injury. And in an earlier publication, we actually found that treatment with ceftriaxone after traumatic brain injury, prophylaxis against some of the post-traumatic seizures. What we're seeing now is something very interesting. In the right-hand panel is that paired pulse metric, where the higher on the y-axis we are, the less intracortical inhibition there is. There's a missing couple of words there, but the dotted line is a group treated with ceftriaxone. And so it turns out that, oops, bear with me, that if we apply ceftriaxone, that prophylaxis against seizures, as the graph on the left shows, we have a preserved cortical inhibition. And again, what we can do in rats that we can't do in humans is we can look at the organ in question, we can look at the tissue, and sure enough, by real-time PCR, we have a preserved expression of GAD1, which is an enzyme necessary for synthesizing GABA, and a coarse marker of how dense the population of GABAergic interneurons is. So again, the diagnostic capacity here is to measure whether cortical inhibition has been affected by either injury or an intervention. So thanks. We're happy to take any questions. We have lots of collaborators, and we're delighted to talk about our work anytime. Thanks.
Thank you, Alex. I think we have to move on to the next session. So we'll take, maybe we could catch him in the hall. Yeah.
Whatever you want to do.
Oh, no, we have to move on to
Okay.
next session.
Sorry, Dr. Rodenberg. So I wish, please, for my colleagues to join me. And on the right, I've been asked a dextera, because it's better for the webcast, please. I'm going to introduce everyone while they're coming up because time is short. We have Jen Buelow, who is Vice President of Programs and Research from the Epilepsy Foundation. Rajesh Ranganathan, Director, Office of Translational Research, NINDS. Steve White, who's the Research Director for CURE, and is, of course, the ASP program. And Bree Giamaranino, I knew I'd screw that up, Bree, who works as the cause director for Indiegogo. Now, each of these people has some talking to do first before we have a panel discussion. So I'm going to ask in order, Jan, Rajesh, Steve, and Bree to come to the podium and give their talk. And we've allowed a special little extra time for Rajesh because he's going to talk about the new blueprint program of NINDS. Jan?
You can go to the next slide, because I now know who I am. Or do I do that? Okay. Well, thank you, and I'm excited to be here. This is actually the first time I've been to the Pipeline Conference, because as many of you may or may not know, I just started at the foundation in July, and this is all very new to me. And in fact, it's been a rather high learning curve, and I've had to spend a lot of time this year thinking through what research means at the Epilepsy Foundation. And in fact, when I started with the traditional view of research, because I actually got my first grant from the Epilepsy Foundation. I came to the Epilepsy Foundation from Indiana University, where I was on faculty. And so my original thoughts were, you know, the traditional research, seed grants, fellowships, etc. But I learned a lot over the years. There was a lot of angst involved in research in the beginning, trying to figure out who's paying for what and what's important and what isn't. And there was some tussles about why, you know, who we should be reporting to, etc. And I learned a lot from ETP. And as I joined, that was also kind of the time that we were merging with the epilepsy therapy projects from the Epilepsy Foundation. And I didn't have a lot of interaction with ETP before I got here. So what I learned over the years was that over this year, was that we needed not to follow research, but instead we needed to start driving research at the Epilepsy Foundation, and that we needed to be at the cutting edge of bringing treatments to patients more quickly. And I think I really learned a lot of that from ETP. So I have a schematic up on the slide. It's my one slide, happily, for everybody here. And I was thinking through, what does research mean at the Epilepsy Foundation? And so right at this moment, this is kind of what it looks like. And I thought about, well, it's data, it's therapies, it gets to the people, but what does that mean at the foundation? So right now, we fund pre-docs and postdocs. We have something new this year. We're going to be funding we're calling them innovation postdocs, so that would be postdocs who are working not in traditional labs, but instead in innovation in places where we believe things are happening in an innovative way. We've always had some seed grants. Something new we're starting this year is rolling seed grants that address timely topics at the time that we need to be funding them. we are funding new therapies, and that's, of course, as you all know, that's what this whole program is about. And SEAL Awards, which we will also be hearing about, I think, right, Roger, in this conference? Okay. And then, and another part of research is something that's new, and that's partnerships. What we didn't talk about a lot is sort of the top half of that. And what I wanted to say kind of about that is if you look at those, at sort of the top half, patient engagement, communication, disseminations, I think at this time, I need my glasses so I can see what I wrote. We need to start, we can't really be doing business like we used to do business at the Epilepsy Foundation. Instead, we need to have patient-driven research. We need to make sure that every single dollar we spend is going to have an impact on patients. We need to have a faster turnaround than we used to have. We need to disseminate better. And actually, I thought about this when we were hearing about Visualase, and I was thinking, why do we not have a place on our website where patients can go to say, where can I go to find these new treatments if they're not easily available? So, Ken, that's something we can work on. Yeah. We need more partnerships. I will say that right now we have one, I think, good partnership, and that is we have a PCORI grant, and that is a partnership with a lot of rare epilepsy groups. The partnership is not really meant to have the Epilepsy Foundation sort of be over all these groups, but instead we really are partners. They are driving this research. These are patient and families who are driving our PCORI grant, which is building a database to get more information about each one of these rare epilepsies. And so this is kind of a first, and it's part of a much larger consortium of patient-driven research and clinical data research networks that where we can be working back and forth to be using computational phenotypes, perhaps, to identify patients who haven't been able, that we haven't identified for diagnosis purposes. So these are for the rare epilepsies. So that's one partnership. But probably we need to be working together more cooperatively and in a more partnership manner with NIH, I think. We are already working with Polywog, who we'll be hearing from today. And finally, I think that we need to be the leaders in what kind of cutting-edge research is going to be happening for the patient population that we are representing. We are a patient advocacy organization. Our organization is meant to be here for people with epilepsy and their families. And it can never be about the Epilepsy Foundation. It has to be about people with epilepsy and their families. Research is meaningless, unless that is the very front, the very forefront of why we're doing what we're doing. So this is just a snapshot of Epilepsy Foundation's research, and I've tried to be brief, and
so I think we'll hold questions till the end for the panel. So Rajesh.
Could I have my slides? Okay, thank you, Roger, for the opportunity to talk here. So what I'm going to do is I'm going to sort of walk you through a little bit of some of the changes we're making at NINDS to support translation. So I'll begin with sort of some guiding principles. So first of all, when we think about translation at the NINDS, what does that mean for us? And we sort of put these 3 points here in terms of really trying to get that therapeutic to the human and using translatable markers of PK, PD, and target engagement, and integrating that clinical perspective, which often has been missing in the past in some of the programs that we put together. And sort of establishing more of a fail fast, fail early approach to managing the portfolio of projects that we do. So we use milestones to do that, and we embrace the early terminations that we make actually as a success of the program in terms of opportunity cost, but also potential to learn how to do things differently. And to echo the things that have been done by, mentioned by others, this is an ecosystem. We can't do it alone. And the partnerships and the handoffs are very key. And so we're focusing on really thinking about what can we do to de-risk projects such that some of the funders in the room or others might wish to pick up and run with them after we're done with it. And one of the things we're doing, which hasn't been done in the past, is NINDS is taking an active effort to actually facilitate some of those partnership conversations. So we're being sort of like Match.com, if you will, for your projects in trying to get the funders to the table who might potentially be have the right risk appetite for the program at the stage that you're at. We started this at the JP Morgan meeting in January, and have done that consistently, literally every month at one meeting or the other this year. So it's a new effort for us, and we've sort of put investigators in touch with funders in a way that they potentially might not have had a chance to do that. But at the end of the day, what it really means for me anyway is that translation begins and ends with the patient. And that's, I think, a theme that's also been echoed by previous speakers. And so, Jackie started this morning with the comment of, it's not business, can do business as usual. And I think that also goes for, what we need to do. So let me sort of first give you an orientation of where things are at. So you've seen this diagram from John Keane this morning. These are all the programs that we have in the Office of Translational Research at NINDS. And the anti-convulsant screening program right at the top has been discussed several times, so I won't say anything more about that. But what I'm really going to focus on is in this middle piece here of these programs that support the bulk of our translational efforts at NINDS, and to the tune of about $60–70 million in those buckets. So the current programs, if you're not aware of them, there's a program that's usually referred to as the U01 program. It's all comers in terms of modalities, small molecules, proteins, peptides, oligonucleotides, you name it. We've got about 34 projects in there. They're milestone driven, and amounts of money. These are direct costs, $1 million plus per year times 5 years. We've had a precursor program to that, which is the translational R21 program, which are again all comers. We've got 53 projects in there. They're not milestone driven, smaller pockets of money for smaller periods of time, in essence to get ready, if you will, for the U01 program. But however, what we've noticed in some analysis is that the end goal of those R21s to a large extent has been something other than getting ready for the U01 program. And this is an analysis of the past 10 years. And so really requires us to rethink what that bucket looks like. And then there's the third program, which some of you may be aware of, which is the Trans-NIH Blueprint Neurotherapeutics program. And I call it 1.0 because I'm going to tell you about 2.0. And this program is for small molecules only. And we had two active NINDS projects in there out of 5 that were initiated. And it's a different structure. It's a contracts and consultants in the virtual pharma network, again, milestone driven. And the sort of overall value to the people who might be in the portfolio is about $2 million per year over 5 years. So you essentially get $10 million of funding if you go through the entire cycle. So these are the current programs. So what are we going to do? So I've been in this job for 2 years. We've taken stock of all of the processes, and what we're going to do is we're going to replace these 2 programs that are going to disappear on this slide. Those 2, okay? If you were looking at your Blackberries, look up, okay? These 2 disappear, and then they're replaced by 3 new programs. One is a track, because we're calling Blueprint 2.0, that'll be dedicated for small molecules. And then 2 programs that had the acronym CREATE that is spelled out at the bottom, Cooperative Research to Enable and Advance Translational Enterprises. One for biologics, which is everything that's not small molecules, and a specific one for devices. Given that we've had 2 sessions on devices, I would like you to be aware that we fund a fair amount of device work, and we will be funding it going forward as well. So I'm going to spend a few minutes talking about these programs and the features of the new programs so you have a sense of what's coming down the road. And you'll get all of these. Actually, you're the first public forum in which this is being discussed. This was formally approved last Friday at our council so that I'm able to speak about it. And I'm circling this R21 piece to point out that this is still under revision. We haven't done anything to fix that part of the pipeline. But if I were to come back here in a year from now, I could tell you more about what we're doing there, or maybe I might mention it a little bit tomorrow in the 10 minutes that I have in terms of gaps in translation. And one of the challenges that we have is really the gap to feed the pipeline in terms of these programs that we're setting up. So the Blueprint Network, the way it's structured, is that there's a lead development team that consists of the investigator, seasoned industry consultants that we hire, and then the NIH staff. And that team accesses all of the various contracts that we already have in place, 4 of which are listed: AMRI, CDD, Southern, and SRI. And then we have formulation and manufacturing and phase 1 contracts currently being put in place as the projects are maturing. And so we run the projects through these contracts, and the bioactivity work is done back at the investigator's laboratory, whether they be at the company or at an academic institution. The consultants, if some of you may recognize some of the names here in the various arenas, are currently on retainer, if you will, to be used by NIH, and we're constantly looking to add new people to the roster who are able to help us guide these projects to move forward. Okay, and the portfolio 1.0, that's the existing portfolio, which was funded to the tune of $50 million with common money pulled from 15 different NIH institutes, had these 15 projects that were brought in at the various stages as listed by the length of the bar. The blue ones are the active ones. The red ones are ones that we have terminated for a variety of reasons, most of the time for not meeting a scientific milestone that was pre-agreed on. And once that didn't meet, we expected a fair amount of attrition in this project. A couple of the projects, after Blueprint decided to walk away from them, the specific institute in whose mission that particular project fell decided to still continue funding them. So for example, the hearing loss project with Ed Rubel from Seattle got picked up by the Deafness and Communication Disorder Institute. And we did the same, for example, at NINDS with the narcolepsy project with Humphreys. When it was discontinued, we felt that it was sufficiently important that we would use NINDS money to continue funding that. Okay, I didn't list who's a company and who's an academic, but basically it's a 50-50. 50% of these are for small companies, and 50% of them are academics. Okay. So what's the need for 2.0? And I think it's just maybe 3 points here. One is that there is no other NIH program that offers medchem services dedicated to neurotherapeutics, and we wanted to be able to do that. The second is there's very limited access to the IND enabling studies that have been mentioned already twice this morning, the Bridges program, both by Mike and one other person. And the challenge with Bridges is it's funded to a very small amount. It's $10 million a year. Actually, it's smaller this year now that Common Fund has run, Common Fund funding has run out. And so it funds 1 to 4 projects a year across all of the therapeutic areas that Bridges is supposed to accommodate. So we wanted to make sure that the projects that came in and that required IND-enabling activities could be done through NINDS resources. And in all of the discussions we've had, the interest in the Blueprint approach of essentially having these contracts and accessing them continues to be robust. So for these reasons, what we've done is we've gotten permission to essentially relaunch 2.0. But we've changed several things about how it's run. First of all, in 1.0, you basically came in and you had to do all of the work through the contracts. And we've learned that that's not necessarily a good way to do this because there are some applicants who've come in with very strong expertise in medchem or some other area, and there's no reason for us to use contracts to do this if they have that in-house. So here we'll have a lot more flexibility to decide what gets done through a contract and what gets done through the investigator's laboratory, and you have the option to choose that. Now, if you wanted to have a standard grant-only option like the U01, you could do that. You could say, I want 100% of the money, and I just want to do it myself. I don't want any of your contracts, so be it, and we can, that'll be similar to the U01s, and we'll have to discuss whether that's the best way to run the project if it gets funded. The other one was that in the first iteration, everything had to come in and be ready for medicinal chemistry. And we recognize projects don't always have to come in at that point. It could come in at multiple different the stages along the way, all the way through to IND. So there's a flexibility in entry point as to where it comes in. Phased funding, which I'll show you in the diagram in the next one. And then there's cost sharing, which actually in principle allows this not to be capped as 1.0 was at 50 million, which is that there's a course infrastructure that is paid by common money by the 15 institutes. But any given institute will pay for whatever projects they wish to have funded from their own pot. So mental health or NINDS isn't limited to funding only those projects that all 15 institutes can sing kumbaya about. It can essentially put in its own money to fund as many projects as it wants to in this space. So that will hopefully give us flexibility to do that. And then another key piece was that in 1.0, we didn't have a specific track for SBIR opportunities, and now small businesses can use the SBIR track to essentially apply for the same resources. And the staged program is essentially the U01 mechanism is replaced by a new mechanism, relatively new mechanism to the NIH, which is called a UH2, UH3 mechanism. And between the UH2 and UH3 phases, there is an administrative review that allows the project essentially to continue or be terminated. And so what 2.0 will be structured in is that there will be a smaller pots of money, and we've sort of tentatively sort of talked about $0.3 or $0.5 million. We haven't decided on the exact $500K for up to a year, and you will do some early preparatory activities there to make sure that the larger investment that we're going to make in hit to lead opt, or if you're going directly into IND enabling and whatnot, are justified. And sometimes the preparatory phase may be just a couple of months. It's just enough to get the team up and running, for example. So it really is to ensure that and this is based on experience, which is that we, from an NINDS sort of governance perspective, want to make sure that the applicant that sent in the 12-page application and got peer reviewed and said, yes, this is what I have, is indeed what they actually have, because we have learned by hard experience that an assay that's supposed to drive SAR doesn't end up then driving SAR after we have decided to fund it. So this will allow us to essentially manage that challenge. So I'm going to switch to those of you who don't work in small molecule space but want to think about large molecule space, and that's the CREATE program. And there are two tracks again, but the biologics track as well as the device track. And in the biologic space, so this would be for peptides, like Steve's Galanin, for example, there would be two tracks. There would be the UO1 track for the initial part, which is the discovery phase, what we're calling the discovery track, and then the subsequent track, which would be the development track, which would have, again, a UH2, UH3 component. And the one thing I forgot to mention right at the beginning is both the 2.0 and the CREATE programs stretches something that's quite different from what their predecessor programs was, which was everything ended at the IND before then. Now everything goes past IND into early clinical trials if you wanted to. So we're hoping to make that transition from preclinical to clinical space with NINDS funding more seamless. And so that there isn't a stop and start for 9 months where you have to reapply for a clinical grant. You could essentially do that without losing a step. And that's the plan for essentially having that clinical trial phase incorporated into these translational programs. And so here again, the monies are listed for you, 0.3, 0.5, depending on what the opportunities might be. And then there's an error here. The discovery track is a UO1 single track, which we changed recently, so it should just read 0.5. And then the development track is up to $1.5 million for 5 years, which is very similar. And then those of you who are in devices, we will, in essence, have 3 tracks, one for research device, one for 510K approval, and a third one for PMA HDE therapeutic device approval with the same UH2, UH3 structure. And the monies are listed below in terms of how much these mechanisms will give you in terms of total funding over the period of 3 to 7 years for the entire program. So those are the 3 programs, and the timeline is the announcement will be released in July of 2014. 8 of the 15 NIH Blueprint Institutes have signed on to 2.0. So if for this audience, it's not that relevant because epilepsy is an NINDS's mission, but if you had a disorder that wasn't an NINDS's mission, you could still access the 2.0 resources. But for the CREATE programs, we're releasing them all in tandem. So the first receipt date in October, first review 3 or 4 months after that. And so by June of next year, presumably the first projects will get started with funding. Okay, so I'll leave it there. I have some other comments about sort of translational gaps, but I'll just maybe reserve that either in a Q&A or for tomorrow.
Thank you very much, Rajesh.
Steve?
Thank you, Roger. I will really keep this brief, and it is a pleasure to be able to tell you a little bit about Cure's research programs. Many of you know about this already, but a quick introduction. Just to introduce the team, Julie Milder, Associate Research Director, Tracy Dixon-Salazar, also joined about a year ago as Associate Research Director, and Liz Higgins, who just joined about a month ago as a grants administrator. And many of you will, if you haven't interacted with this talented group, we hope that you will at some point. So Cure's mission is a nonprofit organization dedicated to finding a cure for the epilepsies, and by raising funds and awareness for the prevalence and devastation of this disease. And Cure is one of the largest or the largest non-governmental funder of epilepsy research. So our research program, basically we abide by the mantra, no seizures, no side effects, no exceptions. And that really is the goal that Susan Axelrod and other families set out to achieve some 15 years ago. Our priority research areas are the basic mechanisms to fund research that will aid in understanding the basic mechanisms of epileptogenesis, the causes of epilepsy, we have pediatric epilepsy syndromes, and the development of new animal models of epilepsy and seizures. I think one of the hallmarks of CURE, and one of the things that's really exciting about it, is they are willing to fund what others might consider high-risk proposals. And early on projects that maybe doesn't have enough preliminary data to go towards an R01 or an NIH funded, and the CURE funding helps that investigator get that. And they have funded a number of really exciting projects that have led to a greater understanding of not only the epilepsy, but new therapies moving forward. So we have 6 different mechanisms in which people can apply for on an annual basis. The Challenge Award is $250,000 for 2 or 3 years. Award focused on SUDEP is $100,000 for 1 year. The Prevention of Acquired Epilepsies Award, $250,000 for 2 to 3 years, or over 2 to 3 years. A program that we started last year and was very exciting in the number of outstanding proposals that we received, and is a Pediatric Epilepsy Research Award, again $250,000 over 2 years. The Innovator Award is really another hallmark really of CURE, in which $50,000, you have a novel idea, you really want to you think it's you know, an outstanding idea, we encourage people to apply for that. And then the Taking Flight Award, $100,000 for 1 year, and this is really to help that postdoc or that early faculty member make that transition and get established on their own lab. 2 years ago, or I guess about 18 months ago, we started another program which is aimed at advancing a greater understanding of infantile spasms. This is a team science focused approach to develop a transformative therapy or cure for infantile spasms. And this is a team of 8 investigators to date who really have agreed from the beginning to play nice in the sandbox and share their data, and really to let the science drive the program. And we're really excited about where this is going. So just a little history over the last over 10-year period. Between 2000 and 2011, CURE funded 165 grants at a total of $18 million, almost $19 million. The core mission drives our research priorities. 76% of those went to grants towards the understanding of basic mechanisms, 19% towards new treatments, devices, and new imaging modalities, 4% towards resources such as the SUDEP registry, Pediatric Epilepsy Registry, et cetera. So, you know, we're really proud of this investment. There's been a good return on it, at least a 4-fold return on investment during this same period. The $9.8 million awarded resulted in additional NIH funding totaling almost $40 million. And since the inception and the funded CURE research, there have been 193 publications that have resulted. Lastly, I just want to introduce the Epilepsy Genetics Initiative. This was launched just a couple of weeks ago, and it is CURE is committed up to $1 million over the course of three years, in which to develop an exome genome sequencing database in which clinically sequenced exomes are initially deposited into this database, where goal is for 1,000 exomes in which there's good phenotyping data. and consents from the patients, which will allow reanalysis of and recontacting of them. So we hope that these exomes will be reanalyzed every 6 months. Well, we don't hope, that is the plan. The findings would be reported back to the doctor, and it is to serve as a community resource to drive further research. And so those of you that are out there either treating patients or have studies, and this is something that you might be interested in the future, please let us know. The inaugural collaborators are from Duke, David Goldstein, Boston Children's Hospital, UCSF, the Children's Hospital of Philadelphia, and Australia, if you will. We're also in final negotiations in which we hope to have NINDS listed here as a collaborator on this project as well. So that is a real quick thumbnail sketch of CURE's programs. We would like to encourage any and all of you that have novel ideas about sort of improving the therapy and the overall understanding of the epilepsies. Please look at our website, and I'd encourage you to look at the deadlines for these awards, or if you know someone who is looking for this kind of award, please direct them towards our website. Thank you.
Thank you, Steve.
Bree?
Thank you. It's a treat to be here today. My presentation is brief, called Crowdfunding Health Innovation, though I must say I used to call this presentation The Dog Ate My Grant Application, Crowdfunding for Innovation. So let's move on. How many people here have heard about crowdfunding? Let's just do a quick show of hands. Okay, so pretty much everyone has heard of it. It's become quite a well-known term these days. Oh, do I have the slides here? Probably I do. Perfect. So we share that crowdfunding is actually not really a new concept at all. In fact, the base of the Statue of Liberty was crowdfunded back in 1884 by over 100,000 people who gave an average of 89 cents. But today, we're in a very different world than 1884, and now our social networks and our economic networks are connected in such a way that we can move forward ideas in a way that hasn't happened in the past. We call that democratizing access to capital. My particular role at Indiegogo is focusing on cause campaigns, so anything related to health, education, any nonprofit work, research work, all falls within the area that I focus on. But Indiegogo overall is very broad. We were actually the first perks-based crowdfunding company out there, founded back in 2008 by students at UC Berkeley Haas School of Business and one of their colleagues who had been at Penn. Together, they had three very different reasons for wanting to raise funds from their community and move forward their work. One of them had a father who had died of a rare form of myeloma. He was doing a campaign every year and realized the potential to amplify it through an online campaign. Others were in the arts space and others. But together they said, let's pool our ideas and get our community to support us online and then rally the momentum of the greater world. So they did, and since then we have grown a ton. We're now the world's largest global crowdfunding platform with campaign owners and contributors in over 220 countries and territories. Absolutely anyone can use Indiegogo for anything, anywhere. And that means we have a huge breadth of campaigners on the site. We have millions of people who visit it every week and millions of dollars that flow through the site every week. So why would you bother to crowdfund? I actually think the term crowdfund is a little bit of a misnomer because sure, crowdfunding is about the funds. That's a very important reason to do it. But there's actually a lot of other values that you can get from running a campaign. In particular, you can show that there's proof of demand for your idea. The world wants it to move forward. Right now, we have a campaign on Indiegogo for solar roadways, literally roads that are solar powered. They have digital lights within them. This campaign is started small. It's now raised almost $2 million from over 40,000 people. It's blowing out of the water a lot of other campaigns we've seen, and it's showing that the world wants to see something happen in solar, and this idea for solar roadways is getting people excited. It's a proof of their interest in it. It also can help spread a message, raise awareness. I had a campaign recently for the Neurofibromatosis Foundation that was run by Ian Desmond, the Washington Nationals shortstop. And he ran this campaign, yes, to raise funds for the foundation, but also to share a little-known fact that 1 in 3,000 people has NF, and that's not a well-known stat. So he ran the campaign to raise awareness about this fact. A few examples here that showcase crowdfunding are pictured here. Parkinson's Institute is a campaign that was in the Bay Area. Venture capitalist Bill Draper was a donor to the Institute every year. Last year, he decided that rather than making a direct contribution, he would do it through a campaign and offer his contribution as a matching grant. So he launched the campaign with a $100,000 match. And that amplified his contribution and ultimately led to over 450 people contributing to the campaign, which ultimately raised over $550,000 for the Institute's work in care and research of Parkinson's. Second one pictured here is less on the research and care side and more on taking research to market. The kite patch, as that little kite patch block is called, makes you invisible to mosquitoes. It was research that had come out of the University of California, Riverside, that they were ready to take to a more public place. So they worked with a group called IE Crowd and ran this campaign, taking the technology they had developed and actually putting it into a patch that you can wear. Now they ran this campaign as a buy one, give one model. Nice for anybody to be invisible to mosquitoes. Nobody likes a bite, but life-changing potentially to people in Uganda where a mosquito bite could mean malaria. So they ended up raising many times their goal amount, which enabled them to move this product closer to market and also to move to their next level of trials in Uganda for its effects at keeping away malaria. They're now working on their second campaign, which should be launching in the next couple months. It'll be very exciting. It's a new product. And then this third one is actually a service. Plush Care came out of Berkeley, again, the Haas School of Business, with the idea that they wanted to make the Uber for health, connecting you to healthcare from your mobile device very easily. So they launched this campaign to actually get their first customers, and it was right after their launch of the campaign at an event they held to celebrate their launch that several employees of a company actually went to the head of that company and said, we think this idea is pretty cool. Can you sign up for it for our company? And through their campaign, they sourced their first corporate client. They've now raised up to their goal, and they're moving forward with their work. They're only approved to operate here in California. One of the perks on the campaign, the tokens of thanks you get in exchange for contributing, was the chance to vote on which state they should expand to next. So we shall see. And of course, I'm very pleased to share with you that we have partnered with the Epilepsy Foundation. It's been a treat to work with Kim and the folks running this campaign. Are either of them here in the room? Over here? Andersons? Ah, so nice to meet you. Well, it's a treat to be working with you on your amazing innovation here. The idea behind, I don't know if you've had a chance to share with it yet, but the idea behind this campaign, just to get us all on the same page, is that the Andersons have a child who has epilepsy, and they were not able to sleep at night because they didn't know if they were going to have to help this child during a seizure. So they created an innovation, took their expertise from the hardware space and applied it to create a system that enables them to monitor their child while he's sleeping. And that they've brought to the foundation. The foundation voted it as one of their top most exciting innovations of the year. So they've moved to launch a campaign and get the momentum of their community to move forward this amazing innovation. And I'm actually thrilled to share that since the time I took this snapshot of the slide, the campaign has raised about $10,000 more. And what I would share with you today is that this opportunity of having people in the room who all know about epilepsy more than basically anyone else in the world is a huge opportunity to move this campaign forward, because what a campaign really needs are people who understand that it's valuable, why it's valuable, and you give it credibility. So I would charge everyone here, this campaign has had over 7,500 visits, but I would charge everyone here to make it have double that by the end of this conference. So by simply sharing it in your Facebook or your Twitter accounts, you are going to get this campaign more credibility than most campaigns ever get the chance to have, because you are experts in the room and can share your knowledge. It's all about getting that close community to amplify what you do. Real quick, going to walk through 4 quick fundamentals of a strong campaign, and then we'll close on this for now. Happy to answer questions later. The first key piece of a really strong campaign is your frame. How much are you looking to raise? Why are you raising funds? Why are you looking to crowdfunding? Has your institutional funding not kicked in yet? Are you in between grants? Really share and be very specific about why you're doing crowdfunding and what it will help you to achieve. Secondly is your pitch. That's your film and your text. With respect to your video, the first thing is to have one, because videos make campaigns raise over 300% more than those without, or we find that's correlated. Don't make it too long, make it very personal, share what you're doing. People connect to people first and foremost in crowdfunding. Thirdly, it's about your perks, and again, those are the tokens of thanks you offer in exchange for contribution. People contribute to campaigns because they care about you, or because they care about the purpose of what you're doing, or they want to participate in something bigger than themselves and be part of a movement, or they like the token of thanks they're getting. Perhaps they're getting a service, or they're getting a product, or they're getting an experience. You can be really creative with your perks. And then the final section of a great campaign is promotion. And this is really taking into account the people who know what you're doing and having them amplify your work, sharing it with their networks, spreading the message, even before your campaign launches, when your campaign launches, and throughout the duration of your campaign. It can't be understated, actually, how valuable promotion is, both in terms of your network and having them share it, as well as you engaging with your campaign and sharing updates. Today would be a great time to make an update to your campaign, sharing that you've been here, to engage people in the experience with you. So with that, I will close for now, though I could talk forever about crowdfunding, and particularly the momentum we have seen in the past few years in the health and research space.
Thank you very much, Britt. So, of course, we are running a little behind time, but what I've decided to do is promise you that before 6 o'clock, we will end this session and have our Lifetime Accelerator Award, and I will invite the chairman of the board up here to take charge. But since we have such an incredibly talented panel here, I would like to see if people would like to ask some questions. I have some questions, but I'm hoping that the audience will leap to the microphones here. I can't really see this one, but does anybody have any questions for any of, right there, Dr. Metter, go ahead, go for it. Well, in front, if you want in front of the camera, you can come up here. Yeah, got to get in front of the mic. Yeah, because otherwise the people on the internet can't hear you.
Rajesh, I have 3 questions. You can answer none or all. Number one, given some of the revolutionary changes that are taking place in NIH operations, is there any way to shorten the review time from point of submission to point of funding? That's number one. Number two, particularly in small populations like childhood epilepsy syndromes, we need to employ innovative methods for study design and statistical analysis. Are you including those kinds of experts in review of applications? And number three, is there crosstalk between the FDA and NIH as you get toward IND applications in the design of early phase trials?
No, yes, yes. Oh, you want me to say more? Okay. The beast has its own timeline, so it's really difficult to change that and make a difference. I've learned, I thought I could come in and do something about it, but in the 2 years, we've done some we've shaved some, time off in certain places, but there's a certain sort of life cycle to that space because of the challenges of using the committees, and it's governed by the council calendar and whatnot. So that makes it very difficult. So one of the things I always try to do in managing expectations with especially small companies is please don't come to us when your bank balance is zero. I mean, we can't help you at that point. So come to us when you're going to run out of money in 9 months, because then we can help you get there so that you don't run out of money at that point. So think 9 months ahead if you're going to really use NIH funding as a way to keep your doors open and make payroll and whatnot. So that's I think answer for one. Now number two, yes, I think especially with the focus on rigor and reproducibility and all of the things that you've heard from the NIH in terms of the challenges there in terms of sample size, blinding and whatnot, that has become a pretty strong focus of review, and we are bringing in the right experts to do that. And you've also seen the change on the journal front based on Story Landis's paper in 2012 leading the way, and then Francis and Larry Tabak publishing the perspective earlier this year on the same topic. That journals are also bringing statistical expertise to the review process in terms of accepting application manuscripts as well. And the last point in terms of thinking about, what was the last point?
FDA.
FDA, right. So with NIH and NINDS and FDA have a memorandum of agreement that's now 7 or 8, almost, I think it's 10 years. It's the third round of 5 years that has just been renewed, where we meet once a quarter to talk confidentially about things that are in our portfolio that we would like to get their advice on. And they talk to us about things that they see in applications that they want us to make sure we catch during the review process and advise applicants on. We can't talk to them about a particular application and give advice on our behalf. That's not our role. We are not the regulators, the FDA are, but we have that relationship, but that's primarily with CBER, so that really helps for the biologic side of things. We have not been able to establish a similar relationship with CDER. They claim they're too busy to do that with us or every institute that might then want it. We are setting up a similar one with CDRH for the devices. It is not up and running yet, but we hope that that will be available also to help us guide applicants.
Thank you. Question?
More of a comment. Thank you all for presentations. For the young investigators in the room and some of the clinicians as well, for those of you who are applying for grants that fall below the funding line of CURE or Epilepsy Foundation and certainly NIH, I just wanted to point out that there are many other rare epilepsy groups, some of whom are here this week, who are offering smaller grants and are looking for more novel approaches. So if you have something in mind that doesn't necessarily fit the bill of one of the other organizations, I would really encourage you to approach the smaller foundations, such as the Dravet Foundation, TS, Lennox-Gastaut. On behalf of the Lennox-Gastaut Foundation, I can say that our school of thought is every penny counts for a research project, and if we can fund, just even if it's $10,000 or $20,000, it makes a big impact for our constituents, and I'm sure it will make a big impact in your research. So just something to keep in mind. Thank you.
Thank you very much for that comment.
Roger, can I actually just follow up on the comments? I think one of the important things, and I think Jan also pointed to this, I think in the space of collaborating, I think there could be more collaborations amongst the funding organizations. So it would be really helpful, for example, if the various epilepsy disease societies really learned how the NI and NDS programs work, so they can bring the applicants at the right stage to us rather than too early or too late. And the same way, when we feel we're not ready, they're not ready for one of our programs, we can then direct them to the right disease organization to go get that seed funding, to get that one data package that will make them more competitive in review. And I think that way we can help the community navigate this labyrinth of funding programs that exist in a way that potentially they can piece it together. So at the moment, we often find they knock on our door, they might knock too early, knock too late, they go somewhere else, then they sit and sort of languish for a while, they come back, but they haven't done anything in the middle to essentially improve their program, and then it's sort of deja vu all over again, and it doesn't really help them.
Yeah, and just to add to that, I think that the epilepsy community in general is seeing a lot more collaboration now than we have in the past, and I think that's the direction that a lot of the organizations are going in. So I think that, Jan, you'll probably agree with me that there will be a lot more collaborative grant opportunities in the future.
Right, I think we're lucky because we have iCare now, which is bringing all of the funding agencies together to talk and find a way, because we really do need to build a place that people can go and say, oh yeah, this is what we can apply for now. So I think it's a great thought, Christina, and we'll keep working on it.
We have a question back here.
Yes, hi. Megan with Epilepsy Education Everywhere. And we're not geared towards research. We're geared, of course, towards raising awareness throughout the community about epilepsy. We feel that the more people know about it, the safer people with epilepsy are going to be. But also, the more people know about it, the more research funding will go to epilepsy because people simply know about it. Of course, we need our own funding, like any nonprofit. And we've heard about crowdfunding, but the one thing that's kept us from it is those perks. What kind of things do you give as perks when you don't have a lot of money to begin with?
Yeah, definitely. And one thing to know is that perks are optional. You don't actually have to have them, but we do find campaigns with perks tend to perform better. Now, when I think about perks, I think about those 4 reasons why people contribute to campaigns and make sure that campaigns have perks that align to all of them. So, for example, purpose. People will contribute to campaigns because they care about the purpose of what you're doing. For that, a simple thank you card is really all they need. Our most claimed perk level is $25. The level that tends to get you the most revenue is around $100. And the average contribution is between $70 and $90. So a thank you card, a nice thank you from a student, somebody who was on staff, from your executive director, that can go actually really far, as can traditional philanthropy models of putting people's names on walls. You can have a wall of thanks where donors who contribute at higher levels are in higher font, bigger font on your online website wall. It can be an online wall. So that's the purpose side. Now, from the other perspective of why people contribute their participation or wanting to be part of something bigger than themselves, there's often really creative things you could do. For example, could you have an event in key cities around the country where it's an educational event, but you're also celebrating the campaign and you actually offer tickets to this cocktail hour through the campaign? Could you offer the chance to talk with a celebrity who has epilepsy, who would be willing to share his or her experience in an online webinar format? Could you offer books that were signed by authors that you really think are important in this space? You can really be very creative, and you don't have to do things that actually cost a lot of money. By thinking through your network and the assets you already have, things that might seem sort of boring to you are quite interesting to people who don't see them every day. So it's thinking through things like that. Now, in some cases, if you happen to have Ian Desmond, the Washington Nationals shortstop, who can sign baseballs for you, like that's always lovely. Or if you have
Don't have that luxury.
If you have a company that wants to offer products like Nike making a special product especially for your campaign to offer exclusively through it, those things are always nice, but they're certainly not need-to-haves.
Okay, good. Thank you.
Thank you very much. I think since there are no other questions from the audience, I think I'm going to ask Mr. Warren Lambert and Dr. Jackie French to come up. And everyone up here is excused except Dr. White, who may stay at the podium.
And I, in turn, am really simply going to be a conduit to introduce those who are going to do a proper job of sharing our thanks and appreciation for Steve. And Evelyn Nussbaum, are you also with us? Great, if you can join us as well. We're going to hear from 3 folks who are going to speak a little bit to Steve's accomplishments and contributions to our community. And as a father, I'll just join in adding my sincere appreciation and say how much I've enjoyed working with Steve and getting to know him over the last decade plus that I've been involved in the movement and seeing the incredible role that he plays. Evelyn Nussbaum is a board member of CURE, also the mother of Beatrice and Sam, and a journalist who's written for CNN, New York Times, Wired, and Fortune. I think she's going to share some remarks possibly from CURE and from Susan Axelrod, and she's going to lead off. Roger will follow, and Jackie will finish for us. So with that, Evelyn, maybe you can...
There or here?
Why don't you come up here, actually? Share your thoughts.
So Susan Axelrod, who's the founding chair of CURE, had hoped to be here, but she had a scheduling conflict. So I am the mouthpiece for her today. I am delighted to read a statement on her behalf. It is so disappointing not to be able to be with you all in person to witness this wonderful and well-deserved honor bestowed upon Dr. White. There is likely not much more than I can add about Steve's remarkable scientific contributions to this field and his equally remarkable record of excellence in mentorship. I'm certain that in years to come, future recipients of this award will be so honored because they were fortunate enough to have been inspired and mentored by Steve. I know Steve in yet a different capacity. There have been many watershed moments in the history of Citizens United in Research for Epilepsy, CURE, that I will never forget. One was the day Steve and I had our first conversation about his joining CURE as our first research director. I can remember exactly where I was sitting, how the conversation went, and that I had to pinch myself when it was over, because all I could think was, how could CURE, this fledgling organization on the cusp of developing our first internal scientific team, attract the likes of Steve White? I'd known Steve for years. I was well aware of the attributes that he's being recognized for today. I also knew that there are few people more trustworthy, more thoughtful, more ethically deliberate in all of his thoughts and actions than Steve White. Working side by side with him since November of 2011 in his role as research director of CURE, he has never disappointed, and we have asked a lot of him. We've asked him to challenge and even shake up certain of the cultural standards in this community. We've looked at him for guidance about just how far we can push and in what areas and what directions. Across the board, he has represented CURE wisely and sensitively to his colleagues and to the public. Most importantly, he never loses sight of our end goal, finding the answers our patients and loved ones are so desperate for. Congratulations, Steve, and thank you for always, without exception, guiding us with kindness, wisdom, and your extraordinarily strong moral compass. We, along with the entire epilepsy community, are so very lucky to have you.
H. Steve White, PhD. H is for Harold, by the way. I don't know why he doesn't like Harold. Anyhow, maybe he'll have a chance to tell us. He was born in Birmingham, Alabama in 1955. He and his wife, Catherine, have 3 children and a new house in Seattle. I'm still waiting for an invitation to go salmon fishing, but it hasn't happened yet. Steve and I have been good friends since, he tells me, and I think he's right, about 1983, which reflects a lot on both of us, I'm sorry to say. Steve got his BS in pharmacy and his MS in pharmacology from Idaho State University. He then went to Utah, where he got his PhD in pharmacology in 1984, working with the legendary Dixon Woodbury, late Dixon Woodbury. He was publishing papers with Dr. Woodbury as early as 1984, and these two scientists would team up for a whole series of papers in the next decade. In 1988, he published his first paper with the equally legendary late Ewart Swinyard, with whom he became much closer in the years to come. He would eventually publish 170 papers, mostly on anti-seizure drugs and on epileptogenesis, and he's still going strong. But let's back up in time. In 1975, Woodbury and Swinyard, along with Kiffen Penry, the late Kiffen Penry, and Harvey Kupferberg, who's in his 80s and couldn't make this meeting, formed the anticonvulsant screening program, the ASP, which you've heard so much about today. Swinyard was the first PI in Utah, but by 1976 he became the dean, and Steve was gradually brought into the ASP in part of necessity, in big part of a need for a highly competent successor to Dr. Swinyard. By '86, Steve was officially part of the ASP, and as Ewart became ill, which I remember like it was yesterday, Steve was positioned to take over the job. He has been phenomenal. And I think that everybody who has stood up here today and talked about the wonders of this screening program, part of it is at the NIH in Bethesda, North Bethesda, and part of it is in Utah, and it's really a phenomenal program, and we're greatly indebted to Steve for his part of this. But I need to leave something for my colleague, Dr. Jackie French, to say, so I'll stop here and turn the microphone over to her.
So I think it's about time for Steve to have to stand up. Come on over here. So the first thing I want to say is that we only give this award to people we really like. Never mind everything else. So the first thing is that. And I'm sorry that you can't get the award like our last year's recipient out on a beach with everybody with a glass of wine in their hand, but this will have to do. But I also want to say to Kathy, you know, Kathy probably knows more than anybody how devoted Steve is because of all the time that he spends doing his work, you know, even though I know he's a devoted family man as well. So we thank you, Kathy, for giving him up to do everything that he does. The other thing I wanted to say is that if you noticed when everybody came up here and talked about their collaboration with the screening program, they said two things. They said it was incredibly helpful and it was just really fun. It was really great. Now, how many people say that about collaborating with the NIH, I'm sorry to say? Right? That is a unique thing, and it is very much due to this guy here who not only just, you know, comes and does his job every day, but really has a passion for it and is thinking about it all the time and is thinking about how to make epilepsy therapies better all the time and what he can do in his screening program to make that happen. And also, you know, I just wanted to add that as far as collaboration is concerned, you know, all of us call on Steve because there is only one Steve. There's like a ton of the rest of us, but there's only one Steve. So it's always, Steve, can you do this? And Steve, can you do that? And can you collaborate on this? And can you come here? And he just never says no. He's just an incredibly giving guy. So for all of that and so much more, we would like to give you this award, which is so highly deserving. And, you know, it's not even a little drop of what you're going to also accomplish from here on in. We can't look into the future, but I can absolutely predict that you will do wonderful things still with your life. So congratulations. By the way, before Steve gets a chance to say something, I would like anybody else in the room who just wants to come up extemporaneously and say any words about how great Steve is, please be my guest, all of you who have worked with him.
We will have alcohol after this session, and those remarks won't be captured on camera, but there'll be further toasts.
Probably a good thing.
There are people who want to say things.
Well, my comment is just short, but it was actually, I'm new to the epilepsy research field. I'm also the parent of a very severely epileptic child, and it was actually 2 years ago in this room where I just happened to sit next to Steve during this conference, and he was patient and answered my questions about the science that was going on, and then we continued that relationship on afterwards, and it's because of Steve actually that I then decided to go back into research and to do my part in epilepsy research to help the field. So I wanted to thank you for that, Steve.
Thank you, Catherine.
So I wanted to make a personal comment from my experience of having been at the NIH for 2 years in this role and overseeing several programs, including ASP. And I don't think there's any program within my purview where I've had the privilege of interacting with someone, as Jackie said, who's been so not just professional, but also such genuine care. And I think, you know, Susan Axelrod's words about his sort of moral compass is a very apt statement that comes to mind when I think of Steve. So you've been sort of a great example of how I think things can be done and how compromise can be reached without ever raising your voice.
Thank you, Rajesh.
Well, I can't stay quiet here. I mean, come on. So many wonderful things have been said about Steve. I agree with absolutely every one of them. The ASP program has been absolutely instrumental, as you heard earlier in the day today, in creating so many new anti-epileptic drugs. But for me, the contribution has been even more than that. Steve has really invented the key models that I use in my laboratory every day. So it's much more than just drugs. It's actually the experimental test systems that have become standards in our field. And when I go into the lab every day, I use them. And I don't always think about Steve as the guy who actually invented them, but if you'd sit back and think about it, it's actually true. So for me, it's real personal and important too.
Thank you, Mike.
I just wanted to say one other thing, and that is that Steve is a basic scientist who actually cares what a clinician like me thinks, which is really refreshing, and I really appreciate that.
Well, I want to thank all of you for an incredibly humbling experience. It's going to be tough. You know, I'll probably be doing a lot of reading, but it's hard to be standing here knowing there are drinks somewhere else, and I basically have the last word. So I want to thank Evelyn, Jackie, Roger, Warren, Catherine, Mike, Rajesh, for your heartfelt comments. And they do mean a lot. They touch me. I want to thank the award committee, or the selection committee, for this incredible honor. And it really is to be able to follow in the footsteps of Harvey Kupperberg and Henrik Klitgaard, last year's nominee. Both of whom have been incredibly important to me over the 35 years that I've been in this field. And in my early days, as you heard from Roger, I was fortunate to have trained during an era when you had access to, and I particularly had access to the two giants at that time in experimental translational epilepsy research, Dix Woodbury and Jort Swinyard. And I think, you know, Dick's passion for understanding the basic mechanisms of the epilepsies and the basic mechanisms of anti-epileptic drugs at that time, and Jort's equal passion for developing a process through which drugs could be screened effectively and rapidly, which led to, as Roger said, the anticonvulsant screening project component at Utah, is what hooked me, if you will, as a graduate student just finishing up. And it was about that time, actually, that I started meeting many of you in this room. And it was such a delight. I remember my first American Epilepsy Society meeting when Dixon Woodbury and John Kemp and myself drove from Salt Lake City to Phoenix, 1983. And Dixon, you know, one thing I will always remember about him was his passion, his voracious appetite for reading and talking about the science. And science was to be shared, and he made that, and data was to be shared. And Dixon was driving on that trip, and I'm not going to relive every mile of this, 700 miles from Salt Lake to Phoenix, but we barely had gotten out of, or gotten on the freeway in Salt Lake and headed south, and pretty soon Dixon was, had his arm on the back, on the chair, and his hand on the wheel. And he turned around and he wanted to talk science. And, and I'm thinking to myself, we're not going to make this trip. We're not going to make it there. But Dixon, again, he lived to share science, and Ewart was the same way. Results needed to be shared. They needed to be replicated. Long before NIH was talking about replication and rigor, they were doing it. And that is a really important thing. So during my tenure with the ASP, I have been very, very fortunate to meet many of you over the years. And Hal Cohn, I talk about lacosamide and that success story of how an academic chemist can mean so much for the lives of patients with epilepsy. And all of your efforts over the years have contributed so much to the patient with epilepsy. Jackie, Roger, Harvey, who's not here, Roy Twyman, Rusty. I have learned so much through all of you with regards to what it takes to discover, to develop, and to bring a new therapy to the patient. And every day, I think we all think about that. And unfortunately, despite the efforts of Kiffin and Roger to bring this program, this incredibly important program that I've been so blessed to work with, make it available free of charge to anyone who thinks they might have a drug. And we've seen lots of drugs come on the market. We heard this morning, the need is still there, and it's ever pressing. I want to also really acknowledge the leadership of NINDS and ASP back in the days with Jerry Fishback and Story Landis, Harvey and Jim, now Rajesh and John Keene. The program is in good hands, and they have been incredibly responsive to the voice of the community and the needs of the patient, and also the sponsor who submit compounds to the program. And it has been so enjoyable working with them and seeing the changes that take place and having the support in the program to make those changes, some of which you saw this morning and we discussed this morning. So, I want to thank John and Rajesh who are here, Harvey. I don't know if you're watching, but thank you all for that incredible journey to work with you. I hope it's not over. And I also want to say that with all of the changes that have taken place since Jord's days, it's not the same program, and none of those changes and none of the advances that have been made in our program at Utah could have been possible without the incredible talent of so many technicians, graduate students, colleagues at the bench and talking about where we're going. And their time, their commitment to the patient over the years, and past and present. Many of you may recognize Josie Woodhead, who was Ewert's lieutenant when he first started the program, who's now retired. Hal Wolf, a close friend and mentor, who will be retiring not only very shortly. Karen Wilcox, who is a co-investigator, important in the development of all of the in vitro assays that we're currently using and have used in the past. I just want to acknowledge all of their contributions, and certainly, again, without the technical expertise of the years of experience that has been brought to bear on this problem, none of what we're seeing would be possible. So I want to, I know it's, you're going to get that drink soon. I also want to thank the patients, the parents, their advocates, for really keeping all of us focused on what we're here for. The need for better therapies, more effective therapies, safer therapies. You are the reason that I think everyone in this room is here today. And I think as long as we keep the patient central among everything we do, great things will happen. And we've seen some great science today. I'm just blown away. And Jackie, I can't help but agree with your comment right from the beginning. I mean, it just seems like a renewed level of enthusiasm and excitement. So let's keep it going. And Jackie's already acknowledged Catherine, but she has indeed been beside me for all these years, through all of the ups and downs, you know, and been with, been there. Thank you. Thank you all for what a great, great evening.